So they scheduled me to give 2 consecutive talks in a very cold room. So you can fall asleep if you want to, but I hope I'm able to make the topics as interesting as possible. So the first topic that I was actually asked to talk about was redefining the management of HER2 negative early stage breast cancer. I think in the last decade and a half, this has actually been the most exciting field where we've seen an explosion of data. These are my disclosures. So we know that the incidence of BRCA mutation among patients with BRCA-associated tumors do vary. We know that about 6% of patients with hormone receptor positive breast cancer has a BRCA mutation, and about 17% of patients with triple negative breast cancer will have a BRCA mutation. We know that patients with BRCA mutations are sensitive to PARP inhibitors, and this set actually the stage for the use of PARP inhibitors in patients with metastatic HER2 negative breast cancer. We've had 2 important phase 3 clinical trials in the metastatic setting, both very similarly designed, the Olympia D trial and the EMBRACA trial, that randomized patients to either physician choice of chemotherapy or a PARP inhibitor in the form of olaparib or talazoparib. Both cohorts of patients had to have platinum-sensitive disease, and you can see that in both trials, PARP inhibitors actually did trump physician choice of chemotherapy. There was a 3-month improvement in progression-free survival. So shifting gears and trying to take that data to the early stage setting in the HER2 negative setting, we know that over time the prognostic outcome of patients with HER2 negative breast cancer has certainly improved, but we want to make it better. So one of the questions that's come up is how could we incorporate the use of PARP inhibitors among patients with BRCA mutation positive disease in order to improve prognostic outcome? So there was the Olympia trial, which is a trial that took patients with germline pathogenic BRCA1 or BRCA2 mutation. These were early stage breast cancer patients, HER2 negative. They could have had either hormone receptor positive or triple negative breast cancer, stage 2 or 3. These patients, if they received neoadjuvant therapy, they could not have achieved a pathological complete response. They had to have residual disease. And if they had hormone receptor positive disease, they had to have a CP score, a CPS or plus EG score of more than or equal to 3. And if you were entered into the adjuvant group, that means you did not receive neoadjuvant therapy. These patients, if they had triple negative breast cancer, had to have a more than or equal to a PT2 tumor or an N1 disease. And if they had hormone receptor positive disease, more than 4 positive lymph nodes. And in the adjuvant setting, they were then randomized to receive either olaparib or placebo. And you can see the primary endpoint of this study was invasive disease-free survival. When you looked at the patient characteristics of these patients who were enrolled in the Olympia study, you can see median age of diagnosis was about 42 years, and the majority of patients had triple negative breast cancer, with about 18% of patients having hormone receptor positive breast cancer, and about 26% of patients had actually received either neoadjuvant or adjuvant platinum-based therapy. In terms of outcome from the Olympia study, you can see that there was a 3-year absolute improvement of 8.8% in terms of IDFS, a 3-year absolute improvement of 7.1% in terms of distant disease-free survival. And in terms of overall survival, at the initial presentation of this data, there was a 3-year absolute improvement of 3.7%, but it was not statistically significant. Last year, we saw at the plenary, at the ESMO virtual plenary session, an additional 1 year of follow-up with the Olympia study. There was an exploratory analysis looking at the 4-year IDFS, and you can see that there is still a continued separation of those Kaplan-Meier curves. This resulted in a very rapid adoption. You can see the ASCO almost immediately incorporated it into its guidelines in terms of using adjuvant olaparib in patients with a germline pathogenic BRCA1 or BRCA2 mutation. Now, what about patients with high-risk triple-negative breast cancer? Could we further improve prognostic outcome? Well, the first question, and I wish Sudeep was actually here because the question that we've been debating for so many years, and he's finally presented the data for this at San Antonio, how could incorporating the use of platinum-based therapy actually improve outcome of patients with triple-negative breast cancer? So we had data from the JAPR-6 trial, the CLGB 40603 trial, and the Brightness trial that actually showed that the addition of platinum-based therapy in the neoadjuvant setting did in fact improve pathological complete response. We also had meta-analysis that showed that an increase in PCR rate from 36% to 52.1%, but there was still a lack of consensus until we saw two important pieces of data. The first was the updated analysis of the Brightness study that incorporated platinum-based therapy in that neoadjuvant setting amongst patients with triple-negative breast cancer. And you can see that adding carboplatin to paclitaxel followed by AC, in fact, improved the event-free survival after a median follow-up of 4.5 years. Then, of course, last year at San Antonio, Sudeep presented his data from the Tata Hospital that looked at the addition of platinum to sequential taxane and anthracycline chemotherapy in the neoadjuvant setting. It was a phase 3 randomized controlled trial. You can see that the addition of platinum improved the PCR rates from 40% to 54.5%, so very consistent with what we've seen so far. It also was associated with an improvement in event-free survival as well as overall survival. Now, what about incorporating the use of immunotherapy in patients with high-risk triple-negative breast cancer? Well, we have the results from the Keynote 522 trial. As you know, this is a phase 3 clinical trial that took patients with high-risk triple-negative breast cancer, randomizing them to receive either paclitaxel carboplatin followed by anthracyclines, or the same regimen with pembrolizumab given once every 3 weeks. And you can see that incorporating pembrolizumab improved the PCR rate from 51% to 64.8%, and there was an improvement in event-free survival with an absolute benefit of 7.7% that translated into an almost 37% reduction in the risk of recurrence of disease. Now, when you split the event-free survival by whether patients had achieved a pathological complete response or not, you can see in those patients who had achieved a PCR, adding pembrolizumab actually didn't make that much of a difference. Patients were really doing well irrespective of the IO. But amongst patients who had residual disease post-surgery, you can see that those patients who had received immunotherapy in the form of pembrolizumab, there was a 10.6% improvement in event-free survival. Now, what about patients who've got HER2-negative disease and hormone receptor-positive disease that are also high risk? How could we improve prognostic outcome amongst these patients? Well, the questions that we've asked ourselves is, can we do it by extending adjuvant endocrine therapy? We have a lot of data for that. By incorporating perhaps adjuvant ovarian function suppression in patients with premenopausal high-risk disease, and of course by incorporating adjuvant CDK4/6 inhibitor. Now, we do have data from the SOFT study that shows that adding ovarian function suppression significantly improves disease-free and overall survival over tamoxifen alone in premenopausal women who are at high risk. We also have data from the SOFT in the text. It tells us that using an aromatase inhibitor improves disease-free survival much better compared to tamoxifen if combined with ovarian function suppression. We now also have data from the Monarch E trial that shows that when you add abemaciclib in the adjuvant setting combined with endocrine therapy in those patients who are at high risk, who have hormone receptor positive HER2 negative disease, you are seeing an improvement in IDFS. At the 3-year update, you can see the IDFS actually improved from 83.4% to almost 88.8%. That translated into a 5.4% absolute difference. And this year at San Antonio, we did see the 4-year update of this study, which shows that even post-completion of adjuvant abemaciclib, you're continuing to see the Kaplan-Meier curves continuing to separate, showing that abemaciclib probably also has more of a carryover effect. However, we will need a long-term follow-up data of the Monarch E trial to actually tell us if it's going to allow risk reduction in the long-term follow-up as well. Now, going forward, the questions that we're going to ask specifically in those patients with BRCA mutation positive disease, early stage breast cancer, HER2 negative, the first question we're going to ask is, among patients with triple negative breast cancer who received neoadjuvant therapy and have residual disease, what is the optimal adjuvant therapy? Is it immunotherapy, or is it olaparib, or is it something else? We do have data from the CREATE-X trial that took patients with residual disease post-neoadjuvant therapy, randomizing them to receive either capecitabine or a placebo. And you can see that in patients with triple-negative breast cancer, capecitabine was associated with a disease-free as well as overall survival benefit. However, these patients were not substratified by whether they had BRCA mutation-positive disease or not. So we don't actually know what the benefit of capecitabine was in specifically those patients with BRCA mutation-positive disease. But what did CREATE-X actually teach us? We know that patients with triple-negative breast cancer have residual disease and have a worse prognostic outcome. We've seen that in multiple clinical trials. We know that the addition of adjuvant capecitabine actually improved prognostic outcome. But these were for all comers and were not specific for patients with a BRCA mutation. And right now, there is no suggestion that it would not work for patients with a BRCA mutation. Now, when we go back to the KEYNOTE-522 trial, which actually continued pembrolizumab in the adjuvant setting, irrespective of whether patients achieved a pathological complete response or had residual disease, you can see that giving pembrolizumab, there was a 10.6% improvement in outcome in those patients with residual disease, but we have no information on those patients with BRCA mutation. And you can see that the outcome is still poor. Even though there's a 10.6% improvement, the outcome of these patients are still poor. So in the BRCA mutation cohort, could we do better? Well, when you go back to the Olympia study, you can see in those patients with triple-negative breast cancer, when you're giving them adjuvant olaparib, whether they receive neoadjuvant chemotherapy or adjuvant chemotherapy, there was a significant improvement in IDFS. And in terms of overall survival, as I said last year at the ESMO virtual plenary session, Andrew Tutt actually did present the secondary endpoint in terms of overall survival, and you can see that there is a significant improvement in overall survival when you're giving adjuvant olaparib. Now, one of the questions that we probably are going to ask ourselves, all our patients now with triple-negative breast cancer who are high risk in that neoadjuvant setting are going to receive platinums in the neoadjuvant setting. The question is, would adjuvant olaparib work post-prior platinum use? Now, when you go back to the Olympia study, there was a small group of patients, as I mentioned in the patient characteristics, there was a small group of patients who actually did receive either neoadjuvant or adjuvant platinum. And you can see the confidence intervals are quite wide because the number of patients are small, but the point estimate is in the right direction, suggesting that perhaps, yes, olaparib does work even in these patients. So when you put it all together and you look at CREATE-X, you look at the KEYNOTE-522, and you look at the Olympia study, for me at least, it looks like the 3-year event-free survival is probably the best when you're using adjuvant olaparib in these groups of patients. And of course, you do also have the overall survival benefit. So let me give you a case example. This is a premenopausal woman. She's 39 years old. She was diagnosed with right breast cancer, triple-negative clinical T3 N1M0. She has a BRCA1 mutation. She receives pre-op chemotherapy that's platinum-based with pembrolizumab, and she has residual disease post-op. Are you going to give her pembrolizumab? Are you going to give her capecitabine? She has a BRCA1 mutation. Will you give her olaparib, or are you going to consider a combination? So we did have a roundtable discussion with a group of KOLs, including people from India, and we actually did ask this question, what is it that you would potentially like to give? And the majority of the KOLs actually said that they would give, or their preference would be to give adjuvant olaparib. The next question in those patients with BRCA mutation positive disease is, among patients with high-risk triple-negative breast cancer who receive neoadjuvant and achieves a PCR, would you not want to consider giving adjuvant PARP inhibitor? Now, why is this question important? Because we know that not all pathological complete responses are equal to each other. We know that patients who are clinically stage 3 and achieves a pathological complete response does very differently from that who has a patient who has a clinical stage 2 and achieves a PCR. So if that is the case, would you consider, for example, in a patient with a clinical T4 and 3M0 triple negative patient who achieves a complete response and has a BRCA mutation, would you consider giving adjuvant olaparib, something again that we know we don't have any data for, but again we asked our experts, and a lot of them said no, but the majority actually said that they would consider it, although this would be off-label use. When you go to the NCCN guidelines, you can see that they actually have added that you consider the addition of adjuvant olaparib for 1 year for those patients with germline BRCA1, BRCA2 mutation, who have triple negative breast cancer and who have a more than or equal to PT2, PN1 disease after adjuvant chemotherapy, or who have residual disease post-pre-op therapy. So a potential future algorithm that at least what I consider that I potentially will use in my clinic, patients with a stage 2, 3 triple negative breast cancer who are candidates for neoadjuvant chemotherapy. If they receive platinum-based therapy without IO and they achieve a pathological complete response, they get no further adjuvant therapy. However, you may want to consider adjuvant olaparib in those very, very high-risk group of patients. If they have residual disease and they have a BRCA mutation-positive disease, they will be given olaparib, and if it's BRCA negative, they'll be given capecitabine. If we've used immunotherapy with platinum and they achieve a PCR, they'll continue with adjuvant IO to complete 1 year. And if they have residual disease post-op and a BRCA mutation-positive disease, we give them adjuvant olaparib, although there has been some discussion about thinking about combination of IO plus olaparib, but there is no data to support that. For patients with BRCA negative disease, adjuvant capecitabine or adjuvant pembrolizumab would be considered. Now, what about among patients with high-risk hormone receptor-positive early-stage breast cancer? What is the ideal adjuvant therapy? Well, again, going back to the Olympia study, you can see that there was a small cohort of patients who had hormone receptor-positive disease. Again, those confidence intervals are very, very wide, but the point estimate is in the right direction. I think very hard to make those definitive decisions in those patients with hormone receptor-positive disease because the number of patients here are quite small. Is endocrine therapy enough in this high-risk group of patients? Well, we know when we look at the overall survival benefit, there is a benefit again across all subgroups, including those patients with hormone receptor positive, HER2 negative, but again, the confidence intervals are quite wide with the use of adjuvant olaparib. But we also know, and this data comes from the ESME database, a very large database maintained in France that actually looked at patients in the metastatic setting who had BRCA1 or BRCA2 germline mutation and who had hormone receptor positive HER2 negative metastatic breast cancer. Very few of these patients actually received CDK4/6 inhibitor, and you can see when they were given first-line endocrine therapy, those who had wild-type disease did much better than if they had mutation-positive disease. And I think these results may reflect differences in the oncogenic processes and driver landscape involved in the luminal BRCA-associated metastatic breast cancer. It is really something that we need to think about. We also know from the Flatiron database that at least in the metastatic setting, if someone is given a CDK4/6 inhibitor and has hormone receptor positive disease and a BRCA mutation, their outcome in terms of disease, in terms of progression-free survival as well as overall survival is inferior compared to patients who have BRCA wild-type disease. So what are you going to do in that early stage breast cancer setting? What is the best strategy in those patients hormone receptor positive? You have data from the Monarch E trial that tells you the 3-year event-free survival is 88.8%, but we don't know about those patients with BRCA mutation positive disease. And we have data from the Olympia trial, which is specific for those who have BRCA mutation positive disease. 3-year event-free survival is about 83.5%, and there is an overall survival benefit, really begging the question, in the presence of a BRCA mutation, what is the best strategy? Adjuvant olaparib, or is it a CDK4/6 inhibitor plus endocrine therapy? And if you are going to use both, how are you going to sequence? So this is an example, a case example of a 42-year-old lady, right breast cancer, ER-PR positive, HER2 negative, with a clinical T2N1 disease. She has pre-op chemotherapy, significant residual disease. We would obviously, in this premenopausal woman, optimize her endocrine therapy with ovarian function suppression as well as an aromatase inhibitor. But the real question is, would you consider adjuvant CDK4/6? And she has a BRCA2 mutation. Would you consider adjuvant olaparib? My personal opinion, I think this would be my increasing order of preference. Way down at the bottom would be abemaciclib on its own. One might consider giving abema followed by olaparib, or olaparib followed by abemaciclib, but in my practice currently, we're just using olaparib with endocrine therapy in these patients. So in my last slide, this is a potential future algorithm for patients with hormone receptor positive, HER2 negative disease, who are premenopausal at diagnosis, because we're trying to incorporate everything, but just focusing on those patients who are high risk. In those patients who are high risk, we optimize their adjuvant endocrine therapy. And if they're BRCA negative, we give adjuvant abemaciclib in those patients who are high risk, more than 4 lymph nodes positive or other high risk features. And in those patients who are BRCA positive, we tend to look at using adjuvant olaparib first, and we go back to the MDT and we discuss whether post 1 year of olaparib, whether we should be using abemaciclib in sequence. You can see from the NCCN guidelines, in patients with hormone receptor positive, HER2 negative disease who have a BRCA mutation, using adjuvant olaparib has been recommended based on these high risk features. So should we be concerned about the impact on fertility when we're using adjuvant olaparib? And the reason why I bring this question up is because in my part of the world, almost everyone is premenopausal, and you have a high number of patients who are premenopausal here also in India. And we do have preclinical data that actually shows that PARP inhibitors significantly deplete ovarian reserve of primordial follicles. We also know that diminished ovarian reserve leads to infertility and premature menopause. We don't have any clinical data as yet to prove this. And I think counseling these patients before you start them on adjuvant olaparib is very, very important. And doing egg preservation prior to starting any treatment for these patients is very important. My last question is, can PARP inhibitors be taken to the neoadjuvant setting? Simple answer is yes, we do have data for it, but it hasn't been approved and hasn't been clarified, I would say, in a phase 3 clinical setting. We do have data from Jennifer Litton's group at MD Anderson where they looked at neoadjuvant talazoparib for patients with operable breast cancer with a germline BRCA pathogenic variant. Here, talazoparib was used single agent, and you can see that they had some very decent pathological complete responses. These were all triple negative breast cancer patients, and 70% had stage 1, stage 2 disease. I think very interesting data and something to consider if your patient is not a candidate for chemotherapy. We also have data from the JEPR-OLA study, which we looked at neoadjuvant paclitaxel olaparib compared to paclitaxel carboplatin in those patients with HER2 negative early stage breast cancer. All of these patients had to have HRD positive disease. We saw the updated analysis of this trial at San Antonio this year. And when you focus on those patients with BRCA mutation positive disease, there was absolutely no difference in the pathological complete response between giving chemotherapy with paclitaxel carbo versus paclitaxel olaparib. I think it's cheaper to give paclitaxel carboplatin and probably less toxic. And finally, who should be tested for a BRCA mutation? There are so many guidelines out there, and I'm pretty sure Shani would love to talk to you about those guidelines, because this is your area of who should be tested and when they should be tested. I can just tell you that I personally think all patients with HER2 negative disease in the metastatic setting and early stage setting should be tested for a BRCA mutation. So take home messages: adjuvant PARP inhibitors among patients with BRCA mutation who have high risk HER2 negative disease improves prognostic outcome. I've shown you that data in the Olympia study. We know that incorporating IO therapy among patients with high risk triple negative breast cancer also improves PCR and event-free survival. We also know that adjuvant CDK4/6 inhibitors improves outcome of patients with high risk hormone receptor positive HER2 negative disease. But going forward, we're going going to have to integrate all these strategies. And I've just given you a flavor of how you could potentially look at those algorithms in the future to optimally sequence your patients so you can achieve the best prognostic outcome. So thank you very much.